and it's a pleasure to come and talk to you today. I clearly have been given an uphill struggle here, and you know, we have these very fierce endovascular proponents, and you know, they're out there breaking new ground, and sometimes my colleagues think that I'm sitting there contemplating chewing the grass, and maybe they want to put me out to pasture, and they think I should retire. But you've already seen this. This is the challenge, really, is that task C and D lesions are not a one-size-fits-all solution. There's total occlusions, there's long stenoses, there's common femoral disease, and of course there's disease right up to the aortic bifurcation, the renal arteries. So I think uncorking things at the renal arteries is clearly probably a surgical undertaking. And of course, if you don't fix the groin in surgery, then you've got a problem. And I think we've already alluded to this. You know, you have to find your glasses, and we're very good at looking at the initial pictures and seeing what the short-term outcomes are, and we have a beautiful outcome, but is it reliable and durable? And obviously there are drawbacks. You know, some of our patients aren't fit for surgery. Can we make them more fit? Do we deal with their best medical therapy? And there are issues around length of stay, because open surgery inevitably has a higher length of stay. We looked at the guidelines earlier, and we can see that you can choose between bare metal stents or covered stents due to higher patency rates, and quite rightly we've alluded to devices getting bigger. But with centralization of vascular surfaces, have we got better with open therapy? The consensus document for the European Society says you should consider, if you've got a fit patient, open surgery for C and D lesions. And of course, it does allude to the fact that there may be better patency rates. And of course, the real killer in the document here is when vascular lesions also involve the femoral artery, a hybrid procedure combining common femoral endarterectomy is probably the way to go. And I'd put to you that that is open surgery. These are some results from the Birmingham group, and it clearly demonstrates that there is an Achilles heel of endovascular techniques. Okay, the survival drops off, but the primary patency is also an issue. And if you look at all the data when we talk about equivalence, we talk about re-intervention and secondary patency. And of course, on the matter of fitness for surgery, you can see the much poorer outcomes on the right-hand side of patients who have tissue loss. So I think you have to tailor your approach to the patient. But when I was coming here, the week before I came here, I saw this patient who had come in on my emergency take. They'd had, they're 58, and because they've got a bit of COPD, they're a bit on the large side, colleagues had put an endovascular approach. They'd had a CRAB. And of course, it was a lady with smaller vessels. The iliacs were 7 millimeters, and the iliacs occluded acutely. She came in with a critical limb. And, you know, there were lots of colleagues who said, well, we can recanalize this and we'll put another stent in. When you're putting a stent inside a stent, it gets even smaller. But that's what was done. And I'm reassured that I came here today, or came here earlier in the week, with my colleagues taking this lady to an operating theatre to revise her surgery. But what about the data? You can see here that both the primary and secondary patency is lower in the endovascular group. This is the 2013 meta-analysis. But have we got better? Well, the data was put up earlier about Mr. Salim's meta-analysis, who's a colleague in the Midlands in the UK. And you can see 12 months and 3 years, the patency still lags behind open surgery, apparently. but the mortality is higher, and maybe the morbidity is higher. But the crunch is actually when you look at the analysis in the paper, and the meta-analysis shows that the data crosses the point of no effect. So in fact, the data doesn't support either argument. Is there any randomized data? Well, there is one trial, 200 patients, the length of stay in hybrid repair, and there's the clue, it's a hybrid repair, so it's involving surgery as well as endovascular. The cumulative primary patency, not much different. Limb salvage, about the same, but there appears to be a mortality difference. The challenge here, of course, is like most studies, there is a mixture of patients with claudication and critical limb ischemia. And how do we dissect out that data? So, what about the issues leveled at us doing open repair? Well, I think these big, long midline incisions have gone by the way. We often use transverse. We use Rutherford-Morrison incisions to do open surgery. And endovascular has its drawbacks. You know, there's risks of embolizing the renals and the SMAs, particularly with high lesions. Does it compromise potential future surgery? We know that potentially the outcome is worse. And a lot of the data shows a very high reintervention rate. And again, the crucial issue is open surgery in the groin. So in our study in Birmingham, about 80% of those patients with critical limb ischemia needed outflow surgery in the groin. So here's the crux. Surgery is my best choice. Well, yes, it is if the patient's fit and the patient is durable. But in most patients, you need surgery in the groin to be effective. And that is the crux of the argument. You have to often deal with the outflow. I think we do need more data, and we're currently engaged in the NHS with the EVOC trial, which is randomizing people to best endovascular therapy versus open surgery. And I hope we might come back with an answer across 30 centres in the UK. But I think we should be driven by the data. So thank you very much. And I think maybe we need to learn the lessons of history, and no better place to do it than here.